Good afternoon, everyone. My name is Ricky Blumenthal. I'm a distinguished professor in the Department of Population and Public Health Sciences and a member. I used to have a title, I don't have it anymore, in the Institute for Addiction Science.
We'll forever have a title.
And I'm really excited to have Dr. Josh Barocas here with us. You can read about him online, but I will share a personal reflection, which I think will be more meaningful, hopefully, which is that there are very few physicians in the United States of America doing frontline work that is informed by harm reduction and a commitment to uplifting the well-being and health of people who have serious medical problems, such as Josh. And so he's a real model, I think, for what we would hope to be doing in this medical school and what we need more of in the world. He's also incredibly easy to work with. So I have asked him a couple of times, hey, I've got this stupid idea, can you make it better? And he's been very willing to correct us. So he's a terrific colleague. We've worked on a couple of papers together. I hope to work on more in the future. And so he has my highest endorsement, and I hope you enjoy his remarks. Thank you.
I know that everybody says, thanks for that kind introduction, but that's like really hard to follow up. You set the bar really high. I'm super thrilled to be here. I'm gonna disclose, so I'm an infectious disease doctor. I'm at the University of Colorado, and I try to do work in the research realm that is directly translatable to policymakers. I will disclose not just that I get funding, but more importantly, this is a new talk for me. So, bear with me as I make my way through this new talk, but I thought that it was something that we should talk about. And I think that here, you'll notice that I use the words pre-contemplation to action. We're going to talk a little bit about the stages of change and how we can potentially apply this to our policymakers as they're trying to make what I hope are evidence-based decisions around substance use. I'm going to ask, this actually worked. Please, let's try this. I'm going to be community engaged here. Take out your cell phone. We have no idea that this is going to work. I've never used this before. If it's a big flop, then we'll see. If you're online, go to slido.com, and this will come up a few times. 6248618. All right. So I come from a state where substance use legislation, or what I like to call substance use adjacent legislation, is really, really hot right now. I know that California similarly has as many, if not more, bills that are being introduced on a yearly basis on the topic of substance use disorder, harm reduction, criminalization, etc. And I know that some of these bills, sorry, I will try to stay on camera. Some of these bills are in line with work that we do, whether it's education, research, clinical, but I think that rarely they're actually informed by on-the-ground work that we're doing, like directly informed. And so I did a quick search of the University of Southern California. I'm not very good with mesh, but Southern California and substance use. It looks like, at least in my very brief search, there were 480 results over the last 5 years. That's about 100 manuscripts per year in the last 5 years on everything from harm reduction to treatment to overdose risk to health economics. An enormous amount of work is coming out of academics, and I think it's rarely being used by policymakers and by nonprofits and by advocacy organizations. And I think we need to understand and work on where the disconnect is and how we can make it better. So I'm a clinician. We're going to start with a clinical case. This is a 42-year-old male comes in for his annual physical exam, no problems, no acute issues, no significant medical, surgical, or family issues. He exercises 5 times a week. He's sexually active with his partner. He's a vegetarian. He doesn't use illicit substances, but he smokes 1 pack a day. His physical exam's normal. His blood work that was completed prior was also within normal limits. So, as the good clinician, we talk about his smoking. He's not thought seriously about reducing or quitting. He justifies his smoking as, quote, his only vice, and he cites his diet and lifestyle that makes up for it. So, interactive question number 1. What's the most appropriate next step? Let him know that you understand where he is, but if and when he's thinking about quitting, you have resources. Highlight the reasons that he should quit, initiate a quit plan with him, or tell the patient that he's killing himself and his mother. I don't know if this works, so, somebody has to, oh wow, all right, it worked. Holy cow. I knew that somebody would answer that he's killing himself and his mother. All right, I'll give you 12 more seconds. So I had a backup slide just in case it didn't work. So clinical case number 2, 55-year-old Republican lawmaker representing a predominantly rural area and a 37-year-old Democrat representing suburban areas present to each legislative session introducing several bills aimed at criminalizing drug use. No past history of success with these bills. One quoted in a local paper that despite his setbacks, he'll continue to, quote, fight fentanyl. The local newspaper reports that same year that lawmaker was charged with a DUI and that he or she covered it up while introducing said bills. The Republican lawmaker is reported to be, though, thoughtful on other issues and kind to all of his colleagues, regardless of party. Democratic lawmakers and nurse, while not in session, both have introduced new legislation to either mandate treatment, charge people with homicide in cases of overdose, so-called drug-induced homicide laws, and both have worked to kill harm reduction legislation, including OPCs. Interactive case number 2. What is the most appropriate next step? Write a newspaper article calling one a hypocrite by name, post on social media calling one murder nurse, testify against the bills that the lawmakers introduce in an effort to kill their bills, not just because they're bad policy, but as a personal vendetta, continue to add to the evidence base regarding drug policy, form a coalition of public health professionals, nonprofit agencies to support or oppose legislation, and connect with the lawmakers and their staff, offering yourself as a resource to inform decision-making. So if I go forward, are you still able to, you're still able to do this? All right. So over the next couple minutes, 45 to be exact, we're gonna have 3 main objectives. The first is to understand how individual behavior change happens through the trans-theoretical framework, whether or not you like individual behavior change or not. There is still a framework, and whether or not you like frameworks or not. Identify key similarities and differences between patient and local policymaker change, and apply those lessons from behavior change theory to local policymakers. So right or wrong, we have the expectations for individual behavior change in our society, especially when it comes to substance use. While we still focus on individual behavior change rather than the societal and social change that actually makes behavior change easier and more accessible, our language around these subjects has slowly changed. During my childhood, it was just say no. It was dare. These were predicated on a success-failure model, an abstinence-only model. And we've slowly are moving toward a more person-centered, empathic approach where we call people in instead of calling people out, where success can be defined differently. And over the last 40 years, or so, we have learned and through this realization that change takes time. Getting from, I don't know, say here to here to here, ultimately to here, doesn't happen overnight. It's a process that happens in stages, and at each stage there's a different need. What gets you from first picture to the last picture, or first picture to the second picture, is also different than what gets you from the third picture to the fourth. And even the first Jack Black may not even know that he has the capacity to be the last Jack Black on this continuum. And so one way that we've conceptualized this process is through the trans-theoretical model, also known as the stages of change model. This should be, for anybody working in the addiction space, this is something that we learn whether as in a master's program, a PhD, or in clinical medicine. And it started as a theoretical construct for behavior change in the late 70s. It happens over time, and it involves a progress through stages. Pre-contemplation, contemplation, preparation, action and maintenance, and also we've added termination. So just to review this for a moment, and I'm not a frameworks person, but since this is all based on this framework, we're going to talk about it for just 2 minutes. Pre-contemplation is when an individual has no intention of changing their behavior. In smoking cessation, which we're going to talk about, this is generally gauged on a 6-month timeline. Discussions with that person focus really on understanding where they are in the process, letting them know that there are resources, and when they feel ready about making a change, that those resources are ready. Contemplation is when the person becomes aware that the problem exists and is seriously considering a change. Individuals here are still in the same behavior pattern, nothing's changed, but there's sort of this intent to change. And so we focus, at least in the clinic, on what we can do to encourage and reinforce that decision to change. Preparation is when you've made the decision to change and they're ready to take action. Specifically in smoking cessation, this is within a 30-day period. And action happens when we make the change. I stop smoking today. This is a period where there's a lot of anxiety, and the focus when I work with patients should be around preventing relapse. What are the resources that we need to surround you with to prevent you from starting smoking again? And then finally, we get into the maintenance and termination phase. Maintenance is when we remain in that behavior state, and termination is when there's really no risk of going back into a different behavior. So there you are. There's the stages of change. I screwed up clicking through. All right, but the amount of time that somebody stays in each stage is variable. And what is required, the tasks that are required to move from the next stage or to the next stage change, but the principles behind them really don't change. So our goal in moving people forward in the stages of change is to reduce resistance, to facilitate progress, and to prevent relapse. The key is knowing what works best at each stage. And this is all based on this idea of decisional balance. What will influence a person's willingness to move forward, or ability to move forward from pre-contemplation to contemplation? It's a measurement of pros and cons. At the end of the day, that's what it is. That we help people understand that the pros of moving along the stages outweigh the pros of staying put, and the cons of staying put outweigh the cons of moving forward, if I said that correctly, which I think I did. And so that combination is what tips people forward. But what changes the balance? It's actually fairly straightforward when we take resources out of it, and we're just talking about personal individual behavior, it usually doesn't come out of the blue, right? In most cases, something has to initiate the change. Something has to change the inertia. And we call these teachable moments, cueable events, however you want to say it. These are moments, statements, events that influence an individual by appealing to either their head, so it redefines a concept or a social role that they have of themselves, their heart, it prompts a strong, effective, or emotional response, or their health. So in this case, it increases the perception of personal risk or outcomes. I actually read recently that, that change happens when a life or health event that's comprised of objective experiences causes an individual to have a subjective response. And that's really what we get with this model for stages of change: your heart, your health, or your head. And I think that over the last 40 years or so, we have had a lot of evidence, at least what those cueing events might be that shift the decisional balance when it comes to, say, smoking cessation. We know that receiving abnormal test results moves people from one stage to the next and quitting. We know that even just going for lung cancer screening or getting a cancer diagnosis among you or a family member is actually a cueable or teachable moment. HIV diagnosis is a really good intervention point for smoking cessation, having a baby, for both either mom or dad, and also why we have so many hospital-based smoking cessation programs, because we've learned that smoking cessation during hospitalization is actually a really good time to change. I was, in preparing for this talk, I really wanted to go historical. And one of the more prominent cueing events, this is a little transgressive, that's not the right word, tangential, is that in 1964, we had about 42% of all adult Americans who were cigarette smokers. And then, sort of under the radar, on a Saturday morning, I looked up the date and made sure that it was a Saturday. In January, the Surgeon General released his first Surgeon General's report on smoking and health. And this was actually the first time that the government had conceded that cigarette smoking caused lung cancer and heart disease and was contributory to all these other problems. This report as a cueing event is I think underappreciated and is sort of enigmatic of what we can do when we get policymakers behind a specific health intervention. So it somehow appealed to broadly the head, the heart, and the health of the general public. And of course, it wasn't enough to move everyone from pre-contemplation to action, but it laid a lot of groundwork. And actually, when we look at studies that have happened since that time, and yes, it was a different time, different social dynamics, different way that politicians talk to each other, it's hard to ignore this. So a Gallup poll that was done in 1968 just asked a simple question: does smoking cause cancer? They looked back in 1958 and saw that 44% of people believed that smoking caused cancer. In 1958. In 1968, 78% believed so. There was really no big other cultural shift except that the government started saying smoking causes cancer. And actually, since that time, smokers have decreased from 42% of all Americans, as I said, to 18% in 2014, which is when this study in JAMA was published. Obviously, not everyone has moved. Not everyone has been cued queuing happens differently, and I'm actually not even talking about or trying to advocate for smoking cessation during this talk. I'm simply trying to show through this as an example that queuing events can look different, and it can resonate differently with people, even at a population level. And over the last, half a century, we see that initiation rates are down, quit attempts are up, and cessation rates are up among smoking. And so we've made progress. There is something to be said about this trans-theoretical model, especially when we couple it in the stages of change, especially when we couple it with adequate resources and we provide people with positive messaging and ensure that they know that they're not failures. This is where the idea of harm reduction comes in. And so when we go back to those clinical cases, our patient in that first clinical case is in the pre-contemplation phase. He doesn't necessarily recognize that he has a problem, and he's, in this case, not ready to change. We, as the clinician, are supposed to be non-judgmental about what one might call his low motivation to change. And our focus at that point is building a strong relationship and trust. If he doesn't come back to my clinic, then I fail, not him. And so the idea is maybe over time, we raise his level of concern, his awareness of the risk associated with his current behavior. We increase his rewards. We'll get into the 5 R's in a minute. But this is where we are with clinical case number 1. And so I saw, as we were putting up the answers, at this stage, we let him know that you understand where he is. If he's ready to quit, we encourage it, but we have resources and we're there for him. In clinical case number 2, it may be clear, but the idea is we don't actually know where our lawmakers are in their stages of change. Oftentimes, we don't take that time to sort of start to figure it out, to ask those questions, either directly or indirectly. And so if we don't know where they are, then how do we know how to move them to the next stage? And so there's actually no right answer based on this clinical scenario. And I will say, I have done every single one of these, including, which I'm not proud of, the murder nurse thing. I've called out our representatives by name. I have labeled people as not nice names. I've sat on testimony for various bills that I oppose and support. I've added to the literature. We formed a whole coalition around this, and I have given my personal cell phone to our legislators to make sure that we are, that they have resources. But again, this is for different legislators, and they're targeting different people at different stages of their change. All we can do is, but what we have to first do is figure out where they are and how we can shift their decisional balance. So, what if we applied a similar approach to our policymakers that we do to our patients? So, interactive question number 3. This is not, I'm gonna give it a second because this is not there's no multiple choice. I actually tried to play with word clouds here. So what's the biggest issue in substance use affecting this area? There's no right answer. It's just a thought experiment for everyone to think about. And I'll give you a second and we'll see if it actually works. Is it working? I can't tell. All right. Compassion fatigue, stigma, addiction, stigma, accessibility, workforce overload, relapse, cost, gentrification, lack of funding, affordability, homelessness, workforce overload, we already said. People are addicted and they feel like they can't change. Preference for punishment, social determinants. This is structural racism, lack of infrastructure, criminalization. It's fascinating. So I think the stigma is like the biggest one that comes up. All right. So in the general Southern California area, we have stigma, criminalization as the two biggest ones. So now, take a minute and think about a policymaker in this area that you could work with. You may know where they are on the stages. You may not. We'll talk about that in a minute. City council, public health department official, state representative, senator, auditor, anyone who, elected or not. I don't think that Jack Black has office yet, but you guys have elected people that I wouldn't put it past the state. All right, so now you've got an individual in your head. We know what the biggest issues are in Southern California. We need to identify where that individual is on the stages of change. How do we get to know that? So there's a practical part of this talk, and the rest of this is actually just hopefully going to be practical for everyone in the room and the large contingent online. So identifying people is not where they are is actually not as hard as we think. So there are the indirect ways. This is how I usually start. What's the past voting indicated? What bills have they sponsored? Have they made public statements about an issue? What does their website say? You can find out a lot about where somebody is in their thinking on substance use based on how they write about it on their website. It's as simple as substance abuse versus substance use disorder oftentimes. And we're talking about stigma, and we're talking about criminalization. That word abuse sort of carries a lot of weight with it. And then there's the idea that once we've started to glean from an indirect method, we take the direct approach. We can speak with them about their position. What are they considering this year? Have they thought about a specific issue? So like I said, the next part of this talk hopefully is going to be much more practical. So my not so big idea is make a meeting with your person. But I understand why there could be some hesitancy. Here's my strength to you. Overdose is a generational issue at this point. It is to our generation what HIV was in the early 80s, early 90s. And everyone has an opinion. But substance use expertise is actually really hard to come by. And specifically, substance use expertise among people who are willing to put themselves out there and make a meeting is even harder to come by. And one of the things that we can provide, whether you are a master's student, an undergrad, a PhD student, a professor without a title anymore, is we can provide that expertise, and sometimes the best thing that we can do is provide just that data coverage. And I use that word. It is lawmakers wanting to do the right thing, but needing to know that they are covered by data. It's almost like an insurance policy. So you have a superpower of being an expert, and you can provide that expertise. So you get your meeting. What are you supposed to do? This is how we compare. We can start to use that framework, that stages of change framework. And again, not everybody's going to be in pre-contemplation. It's not a perfect match, but the tenets behind it, I think, make a lot of sense. So in tobacco cessation, we use 5 A's and 5 R's. The 5 A's are ask, advise, assess, assist, and arrange. So what if we adapt those 5 A's for our local policymakers? So let's start with asking. 5 A's of tobacco. Do you smoke tobacco? You literally cannot find out if somebody is ready to quit if you don't know if they use tobacco. So identify and document their tobacco status at every visit. What about for policymakers? Just because policymaker A that we came up with in that clinical case looks like he or she is somebody that is less likely to endorse a policy, you don't know unless you ask. So what do you care about? Stigma, criminalization were the 2 biggest things that we talked about. So here, drug criminalization laws, personal responsibility, hitting rock bottom, these are all about stigma, and these are all about criminalization. Identify their status on a single topic. I've changed the advise into inform, so this is no longer a 5 A's. So in a clear and strong personalized manner, it's been shown that if you tell people, I think you should quit, even if they're in the pre-contemplation phase, it actually increases their ability to hear other things later. So we normalize it. I counsel all my patients who smoke that quitting would be good for their health. For policymakers, what's your intention? We talk about transparency all the time. I'm a PhD student, and I've been wanting to work with policymakers to help them with understanding the importance of drug decriminalization or stigma. It is setting the stage for what you are there for. In the assess part of this discussion, and you can see this is really trying to frame how to have that discussion and show your superpower. Is the patient willing to make a quit attempt at this time? Have you thought about quitting in the next 6 months? Have you thought about sponsoring legislation, an alternative approach, working with community, listening to a group of stakeholders? Where are they in their willingness to make a change and take a chance? When we try to assist this is about resources in tobacco cessation. What does this person need to get to the next step? And we oftentimes will offer counseling, pharmacotherapy, as many office visits as they may need. For policymakers, we make ourselves available. I'd be happy to meet regularly to go over evidence, draft legislation with you, give you a 1-pager, talk with your staff, make dinner for your family, whatever it happens to be. Help them, give them the resources to make that change. And finally, in the arrange category, or the arrange part of all of this, we never leave a patient hanging. Can we make a next appointment? How can I help? Let's come up with a next step. For policymakers, it's no different. Can we come up with a next meeting? Can we come up with a phone call? We don't necessarily want to end our discussion with them with this was great, thanks so much, with nothing more to move on. So now, moving policymakers to the next stage is what we want to do. Understanding that at any given point, a particular policymaker is somewhere along these stages of change, moving them, creating their teachable moment, their cueable moment is what's next. And so here, the heuristic model, I don't even know what heuristic means, to be honest, but the model isn't different for lawmakers as it is for patients. We need to appeal to their heart, their mind, their brain, or their health. It's slightly different. For policymakers, the heart is oftentimes rooted in what they believe in their political party. For their brain, it's about their senior leadership or what the general consensus is in under the dome. And their health really comes down to their political health, not their individual one. How is there something about their constituents that is going to be a teachable moment? And I will say that context matters. What might be a big teachable moment at one point may be less influential at another. So just like a hospitalization is a really good point for moving people in a teachable moment for smoking cessation, I will say that the last vote of a bill at the end of a session is the worst time to do it. The best places to do it are when they aren't in session, when there isn't a lot going on, when they have time to digest. So context still matters. We just don't have the evidence base as we do in smoking cessation and other behavior change to know what those best teachable moments are. So if you're a PhD student or a master's student and you want a really good thesis, it's when in the policy cycle is best to target lawmakers in changing, in moving them to a different stage of their change behavior. So how do we make sure that we increase the chance that that cueing event sticks? So we talked about the 5 A's. The 5 R's are there to increase motivation when we talk about behavior change: relevance, risks, roadblocks, rewards, and repetition. So can we use these either directly or indirectly with local policymakers? So how do we increase the relevance? And again, I said that this is practical, and I hope that you still have someone in your brain that could be the straw man or the straw person that you can either practice this internally or actually move on. So the 5 R's, relevance. How is this how is making this change personally relevant? With tobacco cessation, it's super easy. You have lung cancer, you are in the hospital. We have created the relevant situation. For policymakers, we have to figure out how to appeal to their head, their heart, or their political health. I put a couple quotes. They're not really that important to read, but I'll say, for practical guidance, if we think about our targeted messaging, to the head, it's to senior leadership. To the heart, it's about your political values or what shaped your political values. And for the health, it's really about helping them understand where the country is moving, or where the jurisdiction is moving, or what's needed and what their constituents might be missing or talking about. Risks, of course, we want to talk about risk reduction. In tobacco cessation, we talk about the potential negative consequences of tobacco use and why they're relevant to that person. For policymakers, there are clear relevant risks to discuss, both of continuing in their sort of old ways and in their current behavior of introducing, let's say, drug criminalization laws. Third, rewards. So can we identify relevant rewards that appeal to the head, the heart, and the health of an individual policymaker? Someone is looking for you to lead on this. We need people to lead on this. And even leading on this will help you secure this constituency or this nomination or whatnot in the next political cycle. I don't love talking about that, but I do think that when we are trying to build that relationship with a patient, we're trying to build that relationship with the policymaker, we have to meet them where they are. Fourth are the roadblocks. What are the roadblocks that get them in the way? This is, again, where those get in the way of quitting or get in the way of behavior change. For policymakers, who do we have to have at the table? What about this doesn't align with their values? Are there groups that we need to pull together so that we can have a more thorough conversation. We know that there are roadblocks to policymakers having behavior change. We have to help identify them and meet and understand that they are real and that we shouldn't necessarily judge them on that. And finally, repetition. This is that accessibility piece. I think that it is worthwhile to acknowledge that behavior change among politicians is hard. We can work on this together. I understand your hesitation. Let's talk more about it. How can I help you understand this better? That repetition and the roadblocks part of this really come down to making yourself as a resource. At the end of your 5 A's and 5 R's, our goals really are to have an understanding of where someone is, determine if there's an inkling of interest in change forward at that time, and to plant the seed for an ongoing trusted relationship. And I will say that results definitely vary, right? So this was our coalition's last session. I took a snippet from one of the agendas. You can see we had some successes and we had some failures. These are both substance use and substance use adjacent laws. And I think that one of the things that we learn in working with patients and that we learn in working with lawmakers as well is, to quote the Rolling Stones, you can't always get what you want, but sometimes you get what you need. So I'm going to tell you a story to wrap this up about both what ends up happening when we try to implement this framework about behavior change with policymakers. So the story of House Bill 22-1326. I was never somebody that ever remembered bills. I studied environmental studies as an undergrad and then was a medical student. I don't know why we name bills boring things, but we do. This is one that is forever ingrained in my brain. So fentanyl in Colorado came up really in full force in 2018. During an election year, which was 22, legislators were hoping to show that they could be tough on crime and tough on drugs. Just by way of the political landscape in Colorado, we live very much like California in a solidly blue state with a supermajority in both the Senate and the House, as well as 4 out of 7 US districts, and the governor, the attorney general, the Secretary of State are all Democrats. I was new back in Colorado and made a lot of assumptions. I had been living in Boston for 6 years, where I didn't have to do anything to convince legislators that overdose was a problem, the overdose was a public health issue. Turns out, not everybody thinks that overdose is a public health issue, but instead, a lot of people up until 2022 in Colorado thought that it was more of a criminal legal issue, that drug use is criminal legal, not public health. And there were a lot of criminal justice organizations working in that space at that time, with a few harm reduction organizations, few substance use organizations in the periphery, but none in a true coordinated fashion. So in 22, the House Bill 22-1326 was introduced. The primary focus of this bill, there was a lot else in there, was to increase criminal penalties for the possession of fentanyl. Everyone was scared. Overdoses had gone up in Colorado since the introduction of fentanyl, as they have everywhere. And so it was to increase criminal penalties for possession. I put on here making 4 grams of fentanyl or more, sorry, I did the backwards, 4 grams or more a felony. What that actually means so 4 grams of fentanyl is a lot of fentanyl. This actually was written as any amount of drug, 4 grams or more, with any amount of fentanyl in it was a felony. So we were somehow, probably because I've opened my mouth way too many times, called people not nice names, I was pulled into discussions with advocacy organizations and with legislators because I was willing to provide my expertise, whatever that meant. It became clear through these discussions that the legislation was going to pass, that the governor wanted it, that the people who introduced the bill had a lot at stake. It was a bipartisan bill. It was an election year. It was going to pass. So then, in harnessing my inner Mick Jagger, we said, the task then is how do we work with legislators to make it less harmful? So along the way, I'm not trying to call out any, these are just pictures of people that were part of this story. We were able to find lawmakers, and the best thing that we did was identify lawmakers at various stages. So Representative Garnett was one of the prime sponsors of the bill and the Speaker of the House with political aspirations, and it was very clear that this was not, that unfortunately the representative was not in a place to think through the ramifications of it, so he was in the pre-contemplation phase. Representative Pedersen, who is now in the U.S. House of Representatives, was also a sponsor. This was not her intent, and she saw a need to make it better, but it was too late in the game, and sort of the political forces around her had overtaken the bill. Representative Herod was trying to figure out ways to make it less terrible. We'll call her in the preparation phase, and was willing to add, what we talked about with her was the need for evidence. So she was actually willing to, and was a huge proponent of adding a large-scale linked data study specifically to Colorado. Colorado, I don't know if you know this, but we think that we do everything differently in the West than, because it's like this Western ethos. We believe that nothing else matters except for what happened in Colorado. So there could be a multinational study that showed that criminalization of drug use was bad, and we would say we need to see this in Colorado. So we were able to move Representative Herod into helping us fund a large-scale study to show the effects of this law on health outcomes. Similarly, we were able to get Representative Herod to draft an amendment that mandated jails to provide all 3 forms of MOUD in jails in the state of Colorado, not just naltrexone. Senator Lee was at the action phase. This guy, I sat with him and Senator Gonzalez in stage 5 for 3 hours. All they wanted was information. They wanted information to go to the floor and argue that this was not a good idea. These folks, what they did, they saw that the battle was being lost, but knew that it was just this battle, and knew that there was going to be more and more legislation. So they helped lay that groundwork for this being not good legislation to go forward. And finally, Representative Herod is a good example of someone who has moved from that preparation because of all of this. This was her teachable moment, her queuing event, in which she has now consistently opposed harmful bills, supported OPCs, and made what is profound, in my opinion, the statement that this was a bad bill. She voted for it, but has come back and said, I should not have done that. In the end, the bill passed. It sucks. It is not great to have more felonies. It doesn't do anything good for our criminal legal system. But through that process, we increased funding for harm reduction services, mandated jails to provide all 3 forms of treatment, authorized the scientific study, and really honestly galvanized a paradigm shift in Colorado, at least locally, in that organizations have now come together, from everyone from the ACLU to to more local organizations and have formed what's called the Right Response Colorado. It's a 30 organization coalition that focuses on the intersection of criminal justice and drugs. It includes public health experts, and so now there is an emergence of experts who have the backing of the coalition to give expert testimony that carries real weight. It's caught the attention of other lawmakers, and so now there are clear rewards for public health focused legislation, endorsements, whereas there are risks for criminalization focused legislation, like some jerk calling you murder nurse. Formation of other work groups to develop data infrastructure. So the Attorney General's office has caught on. They know that data-informed approaches need to be part of the decision-making. And I think most importantly, it's elevated the voices of people with lived or living experience. With every single testimony, with every single coalition meeting, the people who are most vocal and have the backing are people with lived or living experience. So overall, what we are trying to do is change the narrative from substance use as crime to substance use as public health. We've successfully blocked all criminalizing, so that those X's and check marks, blocked all legislation that was criminalizing legislation this year, and expanded naloxone in schools and passed bills on prevention, treatment, harm reduction, and recovery, with legislators texting and emailing at all ridiculous hours of the night for advice, counsel, expertise, and evidence-based decision-making. And so what are the final messages that I can give to you? One, and this is borrowed from harm reduction, because at the end of the day, if we don't have our policymakers at the table, we are just pushing an abstinence-only paradigm, which is, we know in drug policy doesn't work. So meet people where they are. Not everyone's ready to support everything all at once. That we need to be non-judgmental. My calling someone out by name in an opinion piece didn't really work to move that guy anywhere. That our personal beliefs shouldn't play in. Just because I am of one political party doesn't mean I can't work with somebody on this nonpartisan issue. Be a safe, accessible, reliable ally. People need support, and as much as legislators, policymakers may seem like they don't, they really do. They need to know that they aren't alone, that coalitions and community can be influential and can have their back, and that we should be advocating for things that work. This is one of my favorite Josh Sharfstein quotes. We should be investing in things that work and not investing in things that don't work. This isn't your personal agenda, this is science. And so finally, with my obligatory fish slide that has to come into every one of my talks, our summary slide today is that the trans-theoretical model, individual behavior change aside, is a good framework for at least how to think about how behavior change can be applied to local policymakers. Understanding where a policymaker is on an issue is a first step. Identifying cueing events that appeal to the head, the heart, and the political health have the greatest impact in precipitating change, and that changing behaviors takes time, patience, and empathy. With that, I went too long, but I'm still 3 minutes under, and I appreciate this amazing opportunity.